I have been charged with talking to you about the difference between the ILAD standard of care, which was published a year ago, and is a graded guidelines, and the IDSA standard of care. I wondered about doing this in Europe, but as I understand it, much of that standard of care has been brought over here, even though we mostly have a different spirochete. So where do standard of cares come from? In the States, the Institute of Medicine has advised to write standard of care based on evidence-based medicine, which is, and forgive me for reading, but I like this quote, which is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. So what guidelines are supposed to do, according to the Institute of Medicine, is help the general practitioner and the clinician really understand ongoing research, best practices, that they understand a systematic review of the evidence as it comes forward. And they can assess the benefits and harms in terms of an individual patient. And the information should not constrain the healthcare provider. It should enable selection of the best care for the unique patient. This is not really what's going on. It is being used to constrain the provider to follow whatever the guidelines say. So it's important, and the top quote is from the IDSA guidelines, and that's the Infectious Disease Society of America, which I should have said. And it is important to realize guidelines cannot always account for individual variation among patients. They're not intended to supplant physician judgment. This is written in the IDSA guidelines in extremely small print. ILAD's guidelines also say, really, these aren't intended to be used as a cookbook or as a Bible, but rather to be used as guidance in terms of figuring out how to manage Lyme disease in your individual patients. So the ILAD's guideline follow the the IOM's advice that you must grade the evidence. So each study, each piece of evidence that was used in these guidelines are looked at and graded. And how are they graded? So in both cases, ILADS and IDSA, there's a high grade to randomized clinical trials. And do I have a pointer? So you go from here down to here. So both say a randomized clinical trial, which is placebo-controlled, constitutes high evidence. The second, the moderate level of evidence, would be a case-controlled cohort. Similar, similar with the Infectious Disease Society. They like multiple centers if they can, and they mention dramatic results. The low would be an observational study, and the very low might be a case report or something like that. ILADS goes further, according to the IOM, and will downgrade studies if there's a study bias, which you can see sometimes in the intake criteria. If there's a publication bias, some journals won't publish if it disagrees with their editor's stance. If there's indirectness, which if they're very small, et cetera, you might not be able to generalize. If there's imprecision in the outcome, different studies show different things, or if there's inconsistency. They'll upgrade the evidence, and this is shown over here. They just put it into the text. If there's a very large effect, if the study shows a very good outcome, or if there's a dose-response gradient, which is important. And then IDSA simply, again, they were not graded. They have a strongly in favor, moderately in favor, optional, moderately against, strongly against. And what is true in both sets of guidelines is the majority of the recommendations are based on expert opinion because the quality of evidence is not good, it's poor. So these guidelines differ, and when guidelines differ, what's going on is the evidence out there is poor. It's not great evidence. And so the different analyses will take in the different values of the organization. So the International Lyme-int Associated Disease Society puts a high value on the ability of the clinician to exercise clinical judgment. It's felt very strongly that the best person to decide on the therapy going forward is the doctor or the physician sitting in front of that patient who has really done the exam and taken the history. And they also value reducing the patient's risk for developing the chronic form of this disease, which has been so eloquently spoken to by patients here who have indeed been bitten long ago and then become sick much later. The IDSA, on the other hand, has two kind of values. They want to eliminate or alleviate symptoms without causing harm to patients, so it's very important to them not to cause harm, as it should be. They also consider the potential impact of the indiscriminate, I have trouble with that word, use of antibiotics on the development of antibiotic resistance in the community and the economic cost. This is a little odd to me to be in guidelines simply because it's taking a public health issue and trying to apply it in an individual case. I think you have to be careful about that because you can cause harm by taking a generalizable statistical fact and pretending the patient in front of you is that statistic. So ILADs, continued symptoms, can mean persistent microbial infection. If I were to tell you what I think the major difference between the Infectious Disease Society and International Lyme-int Associated Disease Society view on Lyme is, it's right here. That's why this slide is here. The IDSA, their guidelines say, after completion of recommended course of treatment, symptoms almost never improve with repeated antibiotic protocols. And it's unlikely that persistent infection causes post-treatment symptoms. So they really don't think there's a lot of burden of disease, that if you get treated for early Lyme disease with 14 to 21 days of antibiotic, you should be okay. So is there evidence of persistent infection? And this slide is courtesy of Betty Maloney, who is part of the group who writes the fundamentals with me for ILADs. And it's a busy slide, but all these references should be somewhere available to you, and if they aren't, please email me, I'll send them to you. But really, there's evidence of persistence in this disease in case histories through culture and PCR. These are human studies in clinical trials of early and late disease. Many of these studies are European. And then in animal models, we have very clear persistence, and we even now have a human xenodiagnostic study where they took ticks and they put them on people after having treated people for Lyme disease, and they put the ticks on there, and then they put them on somebody else, and they had a really hard time getting those ticks to bite people, but they managed to do it, and showed indeed that you can transmit Lyme even after treatment. So they're viable spirochetes. So this summary, before I go into specific recommendations, ILAD says that this is a multiple infectious process with persistence of infection that continues frequently post 20 to 21 days of single drug treatment. Significant morbidity is found in 10 to 20% of patients, and we'll see later on that truth is it's probably higher, which will reduce the quality of life of that patient to below those of people with congestive heart failure. And Borrelia species are capable of infecting both inside a cell and outside a cell, and acting as stealth pathogens. The IDSA says there's no convincing evidence for the persistence of B. burgdorferi in the skin of humans after treatment. Their guidelines are very precise, and I think for a doctor trying to learn this and trying to treat a patient at point of care, they become a little confusing. There's no convincing biologic evidence for the existence of symptomatic chronic B. burgdorferi infection among patients after receipt of recommended regimens, which is 14 to 20 days for them. But again, there is convincing evidence, I believe. In many patients, post-treatment symptoms relate to the aches and pains of daily living. They actually said that. And I think, again, if you listen to the testimony of the patients here, this is an insulting and painful thing to hear. Borrelia species is an extracellular infection, according to the IDSA. It's easily treated with a single antibiotic. So this is a survey similar to Dr. Opsomer's survey, where she showed you that this is not that survey. This is a quality of life survey that just compares the average quality of life for the chronic Lyme disease patients with other diseases. So they're small, but they're congestive heart failure. The second is fibromyalgia. The third is stroke. The fourth is heart attack. And basically, Lyme tops them all in terms of function and quality of life. This is written by Lorraine Johnson, and it's part of big data analysis. This is a gathering. It is, like Dr. Opsomer's study, a gathering of thousands of patients who answered questionnaires. And it's an attempt to really use big data to come after information in a different direction from the patients. And it involves something called PCORI, which I think sounds of interest to people here, which is an initiative which is the Patient-Centered Outcome Research Initiative. And there is money from the government for research now that requires that patients be involved in the conception and the goals of research studies, if money comes from that initiative. So tick bite prophylaxis, I want to go through this very quickly because I think the group here is much more interested in persistent Lyme. But I think the onset, how we treat people early on, as the last speaker said, if she had been treated adequately, perhaps she would not be sick now. So I think it's important to think about this. And this is a big point in our guidelines, that it is very important, I hope this doesn't happen here, do not use one dose of doxycycline, one 200 milligram dose of doxycycline for prophylaxis of a known tick bite. There's a lot of concern about this. There's evidence this can abrogate the immune response. That means you don't build antibodies, and if you get sick later on, we don't have positive ELISA, and we don't have positive serology. And the role of patient preferences in this, which ILADS also puts into their guidelines, is very low because it's so important not to do the wrong thing here, that we think the doctor should trump that and should tell them, nope, we aren't treating you with one dose. The IDSA suggests for tick bite prophylaxis, you'd give nothing, or you give 200 milligrams of doxy once. And then they give this criteria. The tick has to be attached for 36 hours. The known, wherever the tick came from, there has to be at least 20% infection in the tick. The treatment has to be started within 72 hours. Doesn't matter if you've been camping or whatever. The practitioner must be able to identify stages of ixodes scapularis ticks and tell engorge vs non. Now, I don't know how it works here, but imagine being a busy doctor, you're a busy family practitioner, you're an emergency room physician, and this is what you pull up on your electronic device. You think, okay, well, was it a nymph or was it an adult? And you ask the patient, how long was it attached? I mean, the patient doesn't know. So this, I think, in a sense, interferes with treatment and prophylaxis because it makes it so hard to decide. Now, the issue of if you give that one dose of doxy, what could happen? Well, I just wanted to touch on the concern about resistance, because there's a huge concern. And as I showed, the IDSA is very concerned about not developing resistance, which we should all be. None of us want superbugs. But there's a misunderstanding about how these organisms behave. These are what we call stealth pathogens. This is a great paper in Nature in 2004, changed my world in terms of treating this disease. Stealth microbes are organisms which are smarter than the frontal attack microbes. These organisms have evolved many mechanisms to avoid immune detection, and if you avoid immune detection, you avoid making ELISA antibodies. And they avoid the initial destruction of the bug by complement. For those of you who are not doctors, that's kind of the initial way you go and you crush that bacteria coming in. And then there's an article about TB by Levy and Marshall, and they note that previously inadequately treated individuals are at the greatest risk of acquiring multiply drug-resistant TB. So it's not giving antibiotic, it's giving too little or the wrong combination of antibiotic that gets people in trouble in TB. That's why countries that do not have the means to treat have more resistant TB. They can only partially treat. Mycoplasma tuberculosis and Borrelia sensu are stealth pathogens. The other issue that is a bone in my contention is the chronic use of subtherapeutic amounts of antibiotics for growth promotion in food animals has been banned in the European Union. Thank you. Although I think you have sneaky ways of getting around it, or your agriculture people do. But it continues in the United States. And most of the antibiotics, 2/3 of the antibiotics manufactured in the US are used in animal feed, and it is very clear this leads to resistance. So again, I won't go through this, but the study of the 200 milligrams of doxy for prophylaxis of tick bite, very bad study, and it's a biased study, it's a single study. In the mouse model, the study did not prove to be correct, and so we advise strongly do not do this. So we also advise that you treat 20 days, 200 milligrams of doxy a day, and you educate the patient about how to avoid ticks. So again, the rationale for the IDSA not treating is if the disease does develop, it's easily treated. There's a very low risk of serious complications, and there's an adverse effects of multi-day drug regimens. So treatment of EM, so this is early, and I will run through it too, but again, I think it's important because it avoids the problems later. So ILAD says at least 4 to 6 weeks of amoxicillin, cefuroxime, or doxy, and 21 days or more of a macrolide. Very low quality evidence there. Choice depends on other tick-borne diseases that may be there, severity and number of symptoms, medication tolerability, age of patient, pregnancy status, comorbidities. So you really got to look at the patient and see what you're treating. Role of the patient preference is moderate. Some people will want to avoid too long of an antibiotic or a double antibiotic, even if you find a co-infection. IDSA says EM without neurologic symptoms, 14 to 21 days of doxy, amox, or cefuroxime, and a macrolide, and doxy covers Ehrlichia, so they like it best. Now, their evidence is A1. It's as good as it can get, right? It's a strong recommendation in a randomized clinical trial. Well, let's look at those randomized clinical trials. There are actually 9 of them if you include Stero, which is one from the European continent. And the success rate in these trials are way overrated. they're disease-centered, meaning they prove that the EM rash went away and the fever went away, but they didn't ask the patient how they were. And the statistical methodology is iffy, and this is Cameron's review of those. So none of these trials compared the 4 antibiotics against each other. They all had very small sample size, and only 3 of the 9 trials reported a confidence interval. They were not consistent. Sturl reported 28% overall had post-treatment signs and symptoms, and there was a difference between which antibiotic worked. Maserati reported all doxyazid and amoxicillin probenecid were equally efficacious. And you have to say here, probably they aren't the same bug. One's here, it's Psalus or Guerini, and one's in the States, it's probably Burgdorferi. Directness, only applicable to people with EM without neurologic signs, and in European trials, as it says, the microbe's not the same. So, and this is the summary. Basically, if you look at the failure rates over at the right, you have a 19 to a 38% failure rate. About a third of the patients fail. There's a new study by Alcott in 2013, and he's continued those studies. It's called the SLICE study. It's useful. I didn't think it would be because they're all EM people, but it is a useful study because, look, the failure rate's the same. This is doxycycline given 100 milligrams 2 times a day for 30 days. I think he gave for 30 days. And still you have this failure rate. So, how do you treat EM? Provide ongoing assessments after your treatment. Why? Because those people who have not fully recovered should either continue therapy or be reassessed. Make sure that you've got the right diagnosis and you haven't missed another tick-borne disease or another diagnosis. IDSA says if there's rash, no neuro, that patients treated with macrolide should be followed because there's some, cephalexin. This is a useful piece of information. Cephalexin is contraindicated in Lyme disease, should not be given. And ceftriaxone works well, but they consider it. I'm going to run through these because I want to get to persistent or recurring system, persistent Lyme borreliosis. So, ILADS does not directly talk about late or chronic Lyme, but it does refer to what to do if your patient comes back sick sometime later or does not get well. And while symptoms post-treatment might be due to something else and you have to redo your differential, the bulk of the patients in ILADS assessment, in looking at the data that's out there, is that the patients have a persistent infection, that there's still bacteria, bug, parasite there. And secondary to significant potential morbidity, which again we've heard about, the risk of withholding appropriate antimicrobial therapy has to be weighed against the risk of giving antimicrobial therapy. Again, the IDSA guidelines say very few to no patients have persistent infection, and post-infection autoimmune cause or other diagnosis should be found and treated. Long-term antimicrobial never, they actually say this, solve the problem once recommended treatments have been applied. Now, it's strange because there's really no other disease state. We would not, for instance, withhold treatment if someone had pneumonia and our first 21 days didn't work. We'd try to figure out which bug they had that we weren't covering or what was going on. So this is a multi-system disease, and this is a slide, again, courtesy of B. Zantier. There's really no high-quality evidence. There's observational studies. There's some randomized, very little placebo control. And this is a dated slide. So Luft, in the early days of Lyme, noted that the duration of antibiotics is more important than the concentration. And this is always a push-pull dilemma. Do you have to get very high concentration of antibiotic to make sure you get into the central nervous system, to get into those places it's hard to deliver drug? Or because this is a stealth pathogen that kind of is active, and then it runs away and hides, and then it's active again, and you can kill it mostly when it's active, do you have to give a long-term antibiotic so that you, every time it kind of pokes its head out, you catch it and you don't let it spread and grow? Dottweiler noted that giving steroids pre-treatment was associated with treatment failure. Cameron showed that too. Donta, duration of the symptoms before diagnosis. How long was the person sick before they started therapy affects how long you have to treat. You got to treat longer if it's longer before they're diagnosed. Oaksey, great study in the late 90s, he did 2 of them, showed 100 days. You still had some treatment failures, fewer though, and it was better if you started out with IV and followed up with orals. The route of treatment has to depend on the severity of the illness, duration of illness, and ability to tolerate orals, and there's no specific information for duration. This is the Oaksey study, and I just wanted to show that in the NIH double-blind placebo-controlled studies, 2 of them showed success in relieving fatigue. A great deal of success. And Brian Fallon did something that most researchers don't do. 10 years after this study, he contacted all of his patients. And what he found was 1/3 of them were well. They had never gone back for treatment, and some of these people had been sick for 6 years when they came to treatment. They had been treated for Lyme, told they were cured, and gotten sick, just like some of you here. 1/3 of the patients were not well, but were very grateful. They were back at work, they were back, taking care of their kids. They had to go back for retreatment a couple times, and they weren't 100%. And 1/3 were non-responders, and they're reevaluating the frozen specimens now to look for co-infections and try to see if there are immune reasons, if they can explain that. So this I actually can give in my next talk, so I don't have to do it here. It's a comparison, if you will, of the IDSA and ILAD's conclusions. So I can conclude there. And I am happy, I didn't discuss therapy a lot. I'm happy to answer questions individually about that.